Postema. Ernst is a very good friend from Edmonton. He comes from Holland originally, and he does the I-131 MIBG therapy and scanning with Sandy McCune in Edmonton. And Sandy, unfortunately, couldn't be here, and Ernst stepped into the breach at, it wasn't short notice, but it was reasonably short notice. Ernst, the floor is yours.
Okay. Thank you, Robin, for the very kind introduction. Thank you. I'd like to start the presentation with explaining why I'm using the new interim logo of the Alberta Super Board. You may have heard about the merger of all the 13 regional health authorities in Alberta to one Super Board. I'm not particularly fond of the new interim logo, but I do think that it's important to point out that providing care for patients with neuroendocrine tumors is a multidisciplinary approach. And it's not the Edmonton Cross Cancer Institute approach. No, there are so many people involved in other regional health authorities that I think we should call it the Alberta approach. Well, I'd like to start with showing you the molecular structure of MIBG for a couple of reasons. First of all, so that you can see the very close similarity to noradrenaline depicted on the left-hand side of the slide. The other reason is to show you why we can actually use that molecule to image tumors and to treat patients. You probably see the eye on the south end of the aromatic ring of the MIBG, and that is the eye that can be made radioactive by either iodine-123, which is used for imaging, or iodine-131, used for both imaging and treatment. Well, again, it's primarily an imaging agent, especially in Canada. It's only approved for imaging of patients with neuroendocrine tumors. And again, think of that very close relation to noradrenaline. You can picture why it was the first choice for imaging patients with tumors derived from the nuclear crest, like neuroblastoma or FER or paraganglioma. It has also been used for therapeutic purposes in those patients for over 2 decades now. However, there are still quite a few other neuroendocrine tumors who also take up MIBG. It's actually like the slide that Professor Baum showed, where many of the FEOs also have somatostatin receptors. Well, carcinoids, for instance, have a tendency of taking up MIBG as well. And this is a slide derived from our own data from Edmonton, comparing MIBG and octreotide evidence of carcinoid tumors. And as you can see, quite a majority of people can either be imaged or treated with MIBG or octreotide analogues. And here are a couple of examples. I don't have any rotating slides. I don't have any color slides. It's just black and white. In this case, it's a patient with metastatic carcinoid disease to the liver. And as you can see on the left-hand slide, it's clearly taking up MIBG, whereas on the right-hand side, you don't see any uptake in those liver lesions at all. The opposite can also be the case, like in this particular patient, where you do have octreotide uptake both in the chest and in the abdomen, whereas the MIBG scan is completely negative. But finally, in most cases, scans will look like these, with intense uptake of the octreotide in the tumor and the metastases, but also uptake of radioactive MIBG in exactly the same lesions. iodine-131 MIBG is the radiopharmaceutical that we're using in Canada. It has been approved for imaging of neuroendocrine tumors. Again, any treatment given with radioactive MIBG is considered experimental, which is unlike the European situation where it has been approved for quite a long time. Yeah.
Experimental is still under special access, which you can't do research with.
Correct. I'm going to address that later on. Don't worry. So again, Ian already told us about the difference between a clinical trial application and the special access program. The preferred route would be to use new radiopharmaceuticals within a clinical trial for 2 reasons. You have controlled access. You can publish the data so that everybody will find out what that new approach entails how you could use a new radiopharmaceutical, and a clinical trial can lead to registration of a new drug. Well, I'm not going to get into detail about this because, again, Ian explained that perfectly well. This is the form he was referring to, just a simple 2-page form allowing us to use MIBG for therapeutic purposes. And again, I'd like to thank him for the fact that we always do get approval within 24 hours to use that radiopharmaceutical for our patients. It is still a quite effective drug. And again, I'm referring to what Muriel just said. How do you measure effectiveness? Is it just chromogranin? Is it a CT-based analysis? Do you use PET? No. Most important is to ask the patient how he or she is doing. And I mean by effectiveness that we can control the symptoms that people are suffering from in 2/3 of the cases. We can prolong a period of stable disease. And yes, we do sometimes see biochemical and anatomical responses. So that's actually the goal of our treatment, to gain symptom and pain control, to improve the quality of life of people who are being treated with this drug, and to reduce the requirements for other medication. In the Edmontonian situation or the Alberta situation, the patient selection process is again a multidisciplinary approach. Most people do visit the Calgary clinic at the Tom Baker Cancer Center first, where they will be seen by Dr. Pasika, Dr. Dixon, Dr. Orsted, and either Dr. McEwen or myself. We talk about the best approach that could be taken. If somebody is eligible for a treatment with radioactive MIBG, we make sure that the patient is in condition to actually travel a couple of times to Edmonton to undergo the treatment. Somebody should have normal peripheral blood cell counts. Continence is quite an issue. Again, incontinence might hamper the administration of the radiopharmaceutical because excretion is primarily through the kidneys. So incontinence is a radiation safety issue. If people are incontinent, we probably have to hospitalize them longer to actually give the treatment. Last but not least is, of course, the fact that somebody should have MIBG-avid disease to be eligible for the treatment. We also check the medication that people are using, and we do use the European Association of Nuclear Medicine guidelines. This is actually not the newest version. There has been a new one published, and it's accessible on the internet at www.eanm.org. You can all read it, which carefully explains all the drugs that might interfere with the uptake of MIBG, and we do make sure that those drugs are not being taken during or prior to the treatment. Before we actually give the treatment, we of course obtain informed consent. We administer potassium iodide to block uptake of the radioactive iodine in the thyroid gland. Because nausea is one of the side effects of the treatment, we normally prescribe an antiemetic drug. We very, very slowly infuse the MIBG in our inpatient ward during blood pressure monitoring. And we normally keep patients for 1 or 2 nights in the lead-line rooms at the Cross Cancer Institute. Exception to that rule is patients who live relatively close to the hospital and meet a couple of criteria that would allow them to drive home following the treatment. And again, that's very unlike Europe. That would be unthinkable of, that we could administer doses up to 100 or 125 millicuries on an outpatient basis, but that treatment is really limited to those people who live close by. The side effects that people might suffer from is nausea primarily, which can prolong for almost a week after the treatment. Tachycardia and hypertension might be a side effect of the actual treatment. And even a carcinoid crisis could occur, although, again, touch wood, we haven't seen that so far at the Cross. The majority of people do complain. Oh, I'm sorry. Louder? Oh, okay. Sorry? Speak up. Okay. Oh, yeah. Hopefully this will be better. Is this better? Yeah. Okay. The majority of people do complain about fatigue following the treatment, which can last for a couple of weeks following the treatment. And the most known side effect, of course, is a transient drop in the blood cell counts about 4 till 6 weeks following the treatment. Despite the fact that we give potassium iodide thyroid blockage, there is still a chance that people will develop hypothyroidism during the period that we follow them up in the clinic. So we regularly monitor the TSH to make sure that we give people synthroid substitution as soon as the TSH is rising. How do you actually decide which is the most appropriate dose? And that is something that is still being debated on. There is no common idea how the best treatment should be given. I'm thinking that this is actually not doing very well. Is this better? Yeah. No, there's still that very funny noise. Okay. The dose schedule, so how often should you give it, at which dose level should you give it, how many treatments could you give, there is no common opinion about that. Normally, clinics providing this service give fixed doses to patients, and since the intention is to treat on an ongoing basis, people have a tendency of prescribing lower doses of radioactive MIBG that could be tolerated. And just to give you an example, work by John Buscombe from England describing the results of treating 17 patients with 53 MIBG treatments in total at low doses, again, less than 100 millicuries per dose. And he made distinction between fast-growing tumors, and those people would be treated every 12 weeks, and then went on to a maintenance schedule with MIBG to be given every half year, whereas people who did have slow-growing tumors went into that maintenance schedule from the very beginning. And even at those low dose rates and relatively long intervals between infusions, he did see stable disease in 7 out of 17 people, and partial response even in 6 out of 17. Well, we have a relatively similar approach, where we start with an induction treatment, giving 4 therapies at a 10 to 12 week interval at low doses, again ranging from 3.5 to 6 gigabecquerels, and we do reduce those doses in case of hematological side effects of the treatment. Then we move on to a maintenance schedule. The 5th and the 6th treatment are given with a 16 to 20 week interval, and every further treatment will be given with longer intervals in between, like 6 to 9 months. And we continue the treatment until progression. And again, how do we evaluate? Very similar to what Irel just told you. We carefully take history. We do assess the quality of life provided by the treatment. Of course, we do make scans following the treatment to see if there are new lesions, if lesions are growing, or also the opposite, to see if things are disappearing. We check the blood and the urine every 6 months, and again, despite the fact that I'm a nuclear medicine physician, we don't make that many images. We only make CT scans every 6, and sometimes even every 12 months only. Because again, what's most important is how you're feeling, how you're doing, and we can make a lot of images like these, but if the disease remains stable, as in this particular person, we do not need additional, more fancy imaging. We just follow and give ongoing treatments. And how effective are we? Well, again, the majority of people say that from a symptom point of view, they did notice improvement. 63 out of 85 patients treated with multiple injections of MIBG with a median duration of that response for over 2 years. Just to show you what we also add to well, let's say the quality of life is even a tendency for a longer survival. I'm going to show you data from 2 centers. Center A is the Calgary/Edmonton center, and the other center is an Australian center. And as you can see, we selected a similar group of patients, the same number, almost the same demographic details, Even the sites where all the metastases were localized were very, very similar between the two groups. The treatments they were having concomitantly were also very similar, although you do see that those data are already relatively old, because only a minority of people was currently on octreotide, which is currently the majority of the people who were treating with MIBG. And what we did see, evaluating the data, is that the people treated in our center had a tendency, and again, it's just a tendency, it's not statistically significant, as pointed out at the bottom of the slide, to have a slightly longer survival than people who did not have access to MIBG treatments. So finally, I'd like to conclude with newer developments. I talked about the low doses of radioactive MIBG. There is an American company who is currently doing trials with ultratrace, which is also MIBG, but so-called high-specific MIBG, which means that the amount of cold, non-radioactive MIBG administered to the patient is very low. Almost all of it is highly radioactive. The second difference from the approach that we are having is that they are giving extremely high doses of radioactive MIBG. So the only things that I can show you are the data that you yourself can find on the internet. Again, I'm not allowed to disclose any more details as a participant in the trial, but the objective of this trial is slightly different. They do not focus as much on quality of life and symptom reduction. They're more focused towards actual tumor response as measured by the RECIST criteria. This trial, however, is limited to people having pheochromocytoma or paraganglioma. So most people with neuroendocrine tumors do not have access to this trial. And currently, they are waiting to start the phase 2 trial, and to my knowledge, it still hasn't started. The phase 1 study has been completed, and we're all waiting to hear the results of those. I do think it's encouraging that more people in North America will have access to MIBG, despite the fantastic work that Health Canada is doing by proving the use of MIBG as a therapeutic agent. It should be more commonly available and widely used on this side of the pond. So in summary, I think I can conclude that treatment with radioactive MIBG leads to subjective responses in 2/3 of the people treated, and we do achieve quite significant benefit after giving multiple low doses of MIBG. Finally, again, I'd like to thank all the colleagues, not just at the Cross Cancer Institute, but in particular the ones at the Tom Baker Cancer Center, where we have the multidisciplinary clinics. Thank you so much for your attention.
Thank you, Ernst. I'd like to thank all the speakers this morning. If we could perhaps take a 10-minute break for coffee, and we'll try and get back on track. And so we'll start again perhaps just at about between 5 and 10 after. Thank you.